Welcome to The Scoop from the Lurie Cancer Center's Adolescent and Young Adult, or AYA Cancer Program. We bring together AYA cancer survivors and experts to answer important AYA cancer-related questions. We hope you enjoy the conversation today. Hello, everyone. Welcome to The Scoop. Thank you so much for being here with us today. Today, we have the privilege of talking about fertility and cancer. We're going to start with just a few introductions. So I will start. My name is Bryn Fowler, and I am the program coordinator for the Adolescent and Young Adult Cancer Program, both at Northwestern Medicine and also at Lurie Children's Hospital. Jen, do you want to go next?
Sure. I'm Jen. I am a member of Board 39 and a 7.5-year Hodgkin's lymphoma survivor. I actually have worked with Kristen in the past to run through my fertility treatments before chemo, and my husband and I are actually expecting our first baby in December.
Yay! Congratulations.
Thank you.
And Kristen?
Hi, I'm Kristin Smith. I'm the program manager for Fertility Preservation here at Northwestern Medicine. It's my job to see young, newly diagnosed oncology patients here in the Cancer Center prior to starting treatment so we can talk about options for fertility and fertility preservation.
Awesome. So, Kristen, we just have a few questions for you today, and we hope that everyone finds this conversation helpful. So to start off with, can you just tell us a little bit about fertility preservation and why it's something that AYAs should think about?
Yeah, absolutely. As we've gotten better at treating and curing cancers, we need to think more long-term about life after cancer. And for many young adults, that involves family building. And we want to ensure that we're addressing family building prior to a young adult getting treatment that we know could possibly impact fertility. And so specifically for females, we know certain chemotherapies, specific radiation therapies can decrease the quantity or the amount of eggs that are left in the ovaries. And for women, we're born with a set amount of eggs. So once we lose them, they're gone. And if they're lost to chemotherapy, there's not really anything we can do to get them back. For young men, men make sperm throughout their entire lifespan, but those cells are susceptible to damage from chemotherapy and radiation therapy. So we want to ensure that we're offering things like egg banking and sperm freezing or other options that are available to patients prior to starting what we call gonatotoxic therapy, which is different types of therapy that can damage the gonads or, the ovaries or the testicles.
I think just to speak from personal experience on that, I think for me, being a young adult, I was diagnosed at 24, and you have no idea what I didn't know my life was going to be 6 years from then. And so having someone like Kristen to be able to kind of give you those options was immensely helpful because I was not able to make any kind of decision whatsoever. It was super helpful. But Kristen, you mentioned a little bit more about the fertility options and who the best person would be to talk to if someone wanted to know about the pros and cons of each?
Yeah, for sure. So for men, the most sort of gold standard option is sperm banking, and it's a fairly straightforward process. Here at Northwestern, we have our urologists who see the patients initially for a consult, and then a patient's referred to the fertility clinic for sperm collection and then freezing. And that sperm can stay frozen until someone would ever need or want to use it. If for some reason someone's unable to produce a sample, and that can happen for a variety of reasons, we do have an option for something called a TESE, or a testicular sperm extraction. And that's where one of those urologists that I mentioned earlier can actually go directly into the testicle surgically and retrieve sperm from it. Those individual sperm are then frozen and again saved for the patient for later use. Across the street at Lurie Children's, though, when we have young boys who are diagnosed with cancer and need to undergo treatment, they don't really have an option for sperm banking because they're not quite yet making sperm. But we do know that those treatments are still impacting those spermatogonia cells, the cells that make sperm in the testicles. So those young boys actually can participate in an experimental option called testicular tissue banking. This is where a wedge resection of the testicle is taken out and frozen with the hope that we can utilize that tissue in the future to populate that young man's testicles when he's ready to try to produce some sperm. On the female side, it's a little more tricky, unfortunately. So I mentioned we're born with this set amount of eggs, and really kind of the gold standard option for fertility preservation for females is getting those eggs out of the body before the body sees any treatment. And that's typically done through something like egg or embryo banking. And that process takes about 2 weeks to do. During a 2-week time frame, a woman takes hormonal injections to tell her ovaries to grow lots of eggs at once. She's seen in our office frequently for routine visits, so we can make sure that the response to medications is appropriate. And then we trigger for what's called an egg retrieval, and that's an outpatient surgical procedure where we go directly into the ovary while the patient's under conscious sedation and retrieve eggs. Once we get those eggs, we can either freeze them unfertilized, or if there's a sperm charming, as I like to call it, we can use that sperm and fertilize those eggs, make embryos, and then save embryos. We can certainly also do a hybrid where we're doing some eggs and some embryos. Really is very dependent on each individual, personal situation and kind of what's going on. We also talk with women about going on a medicine during active chemotherapy called Lupron. So Lupron is a gonadotropin releasing hormone agonist. Really big, fun words. But basically what it does is it shuts down the ovaries. So the theory here is that if the ovaries are quiescent, then perhaps the chemotherapy won't do as much damage to the eggs that are in the ovaries. And I say perhaps because it's a big question mark. The data published on it are pretty mixed. There are some studies showing it does help women get periods back after treatment, but not really a whole lot of data showing that it helps women get pregnant. So getting your period back and getting pregnant are two very different things. And while getting a period back is a good sign, it's not a guarantee that there's still fertility. So it's an option. It comes with some pretty hefty side effects that we certainly want to address before someone goes on it. But we do also want to offer that as well. So during active treatment, someone could go on Lupron. There's another option called ovarian tissue freezing. And this is where we surgically go in and remove an entire ovary. And again, this is a process that's done much more often at Lurie children. So when we have young girls, for example, who can't participate in any other option, this is an option for them. So when we go in, we retrieve that ovary. It's got all those eggs sitting in it. We actually slice up the outer edge of the ovary. It's called the cortex. And we freeze those little cortical strips. Those strips could then potentially be transplanted back to her when she's ready to attempt pregnancy. And there have been over 100 live births utilizing that technique worldwide. Wow. But if someone has leukemia or a lymphoma, kind of a bloodborne illness, we don't want to take that leukocyte-rich tissue out of the body and then transplant it back. We could actually reseed her with her cancer. So in those cases, we're really hoping that we figure out something called in vitro follicle maturation, which is where we encapsulate a follicle. A follicle holds an egg in a 3-dimensional alginate system. And then we coax that egg inside the follicle to grow so that we can get one single egg out of that we could then fertilize and then place hopefully an embryo back inside a ready uterus. And it starts to sound like Frankenstein and it gets really crazy. But science, just in the 10 plus years I've been doing this, is moving and moving quickly. And I hope that especially for these patients who are undergoing tissue freezing now, that in the next 10 or 15 or 20 years, we've got these answers for them.
Wow. It's so exciting to hear you talk about the new developments that are coming, and you also explain the options so well. So thank you. One thing I just wanted to back up for a second and ask about is who should be talking to their doctors about this? And are there questions that patients should think to ask their providers in the beginning to know if this is a conversation that they need to have?
I think everyone should ask their doctor, right? If you have a question about family building, you should ask your doctor. And, I feel super fortunate here at Northwestern that I feel like our oncologists do a really great job of 1, knowing about the options, 2, talking about it with their patients, and then 3, making appropriate referrals. And no oncologist should have to be an expert in all the fertility preservation. That's why we have all these fertility doctors ready to go. So I think if there are any questions at all about family building or future family building or fertility preservation, simply ask your oncologist, and he or she should be able to make the referral that's appropriate for you to see a fertility preservation specialist.
Thank you.
Okay, Kristen. I know that you talked a little bit about Lupron, which is something that I did. I can completely agree with you that the side effects were totally miserable, especially mixed with chemo. Hot flashes are a very real thing. just kind of take over completely. But I mean, there's a chance that it actually worked for me because we went through egg freezing and I have not had to use any. So who knows? But which is one of the reasons why we did everything we could do from the beginning. But can you talk a little bit about when the right time is to start the fertility process?
Absolutely. So, I mean, the ideal time, right, is before any treatments entered someone's body. We certainly want to get to a patient before they've started chemotherapy so that we can maximize fertility preservation. We know even that initial first dose of chemotherapy can drastically impact fertility. There's also this question of when you get chemotherapy, is it also doing some perhaps DNA damage to the cell itself? And in sperm, we know that this is the case. So when young men get chemotherapy, it damages the DNA within the sperm. And then if there's damaged DNA and we're saving that, does that lead to an increased rate of birth defects? And there's a huge question mark. We don't know. Mm-hmm. And so certainly the ideal time is before any treatment has started. We also understand that, especially for young adults, sometimes there's been a misdiagnosis, and someone's in the hospital in the middle of a crisis, and we really can't capture them before chemotherapy has started. And so in that case, even if treatment has started, I think it's still extraordinarily important to have the conversation and to talk about still what options exist for me, what are the risks and benefits of those options, and let a patient make a decision about what's best for themselves.
That's helpful. What about once treatment is over? If someone didn't have any of these conversations, are there options for them after treatment?
Absolutely. So it's not a definite, right? It's not that I'm a young adult, I've gotten chemotherapy, I'm definitely infertile after treatment. I mean, you just heard what Jen said, right? She got pregnant without needing to use what was frozen. And, you know, I've been doing this now long enough that I see that in plenty of cases. And, you know, I think, again, if there are any questions at all about current fertility status or what's going on, you should reach out to either your gynecologist or urologist. Certainly you can call me. So I also help with, you know, on the backside of things, kind of that question of where is my fertility right now? And in some cases, after treatment, it's been a year and a half, and someone's not ready yet to family build, they may still have a window where we can try to actively save something. Hi, puppy. And, you know, we should be able to explore that option if someone is interested in that, for sure.
So how long after treatment is there an appropriate time to wait before you start to try to conceive or start a family?
Yeah, so typically this is a conversation that's held both between reproductive endocrinologists and urologists as well as oncologists. And it should be a bit of a team effort in making that decision. Everyone's case is going to be very unique. There's going to be extenuating circumstances based on any additional medications that are needing to be taken, scans that need to be done to ensure that someone's disease-free. And because of that, it's going to be a different conversation for every patient. I can say in general, I feel like for most patients, we're at sort of at least 12 to 18 months after the last chemotherapy dose, where then we're talking about, okay, we feel pretty comfortable with next steps. Let's look at fertility status. And in some cases, it takes about that long for fertility to bounce back. There's this initial hit to fertility, both in egg count and sperm count. And then in some cases, after that sort of year mark, we start to see fertility kind of come back up and those numbers sort of come back up. And I think that's a really good time to start exploring, you know, what's my current fertility status right around that 1 year to 18-month mark.
And I don't know if this is a common thing to do, but I remember having a blood test done that could tell me kind of where I actually fell on the scale of fertility, I guess, for lack of a better phrase. And that was able to sort of help me manage what kind of decision I wanted to make back in the day. But I don't know if that's something that's still done. I don't know if that's even really helpful or can be done for all patients or what.
Oh, yeah. And probably, you know, even since you had it done, it's been widely expanded. So now that's something done actually almost routinely, I think, in a lot of general gynecology visits for not just cancer patients, but for kind of all women, because we have this reproductive window. A lot of women explore egg freezing for a multitude of reasons. And that blood test that you're referencing is called AMH, or anti-Mullerian hormone. And that gives us kind of a rough idea of someone's current ovarian reserve. it's not the best marker in the world. We don't really have the best marker in the world to say, yes, here's the exact amount of eggs that you have. But doing an AMH coupled with something called an antral follicle count, where we do an ultrasound and actually look at the follicles and see them. Then also looking at follicle stimulating hormone and estradiol, which tells us how the brain and ovaries are communicating. It gives us a really good picture of exactly how much of an impact your treatment has had on fertility, and gives us some really good tools for next steps in terms of counseling and thinking about other options for family building.
That's really helpful.
Something I found. Yeah, I definitely found that really helpful. So I'm glad they're still doing that.
Yes. Good.
And Kristen, I know this can be an expensive process. Can you talk a little bit about the costs and if there are programs to help patients with some of these costs?
Yeah, absolutely. So, the unfortunate side of this is that in many states, there aren't mandates stating that insurance companies need to cover medical fertility preservation. Illinois, however, is not one of them. So we actually in 2019 had a bill passed here in Illinois stating that for employers headquartered here in Illinois who aren't self-funded, they should be covering medical fertility preservation. And that was a huge win. It was the state of Illinois saying, we believe in reproductive health and reproductive health rights for our young adult cancer patients. We were thrilled to have that happen. Now, that doesn't always apply to every single person's insurance. So in some cases, there are going to be out-of-pocket costs that can be quite extensive. When we're thinking about sperm banking, we're usually talking the low hundreds of dollars. There are storage fees associated with that. Those are also typically in the low hundreds of dollars per year. There are financial assistance programs through certain storage companies that will help bring some of those costs down. Usually it's something that you have to apply for every year, every 2 years to ensure you meet sort of their income requirements. When it comes to something like egg or embryo freezing, unfortunately, it is a lot more expensive than something like sperm banking. It's a lot more invasive. There's a lot more steps to it. So those costs are typically in the thousands of dollars. And so, depending on which fertility clinic you're with, that cost can vary significantly. We've tried really hard here at Northwestern to make it as affordable as possible, but it's still a few $1,000s. So that's still an extensive price tag. To help offset some of those costs, we do help patients work with a couple of different organizations that can help with that. So the Livestrong Foundation is a fabulous organization that really has a whole fertility program, both for men and women, and it is nationwide. So there are programs across the country who have signed up through Livestrong Fertility. They will provide discounts to patients who have a cancer diagnosis for fertility preservation. And now even some clinics on the flip side will help survivors go through fertility preservation with the Livestrong Fertility. It's huge. And that program provides, through a pharmaceutical company, free medications for the fertility process, which can be a savings of about $4,000 or $5,000.
Wow.
So that's awesome. Yeah. There's another program through a specialty pharmacy and a pharmaceutical company that awards additional free medications for a stimulation cycle. And then there are a couple of organizations that do offer some small grant funding. So Team Maggie for a Cure is a really great one out of Georgia who does some grants available to patients. They will provide, X amount of dollars to help go toward a fertility cycle. The SAM Fund recently has opened up specifically a family building fund that is amazing. We do have a local organization around the Chicagoland area that can potentially offer some oncofertility funds as well. So there are some, and each, university or each academic medical center may have some very specific funding to tap into that hopefully, you can reach out to either a social worker or the fertility clinic itself and be directed towards some of that information.
And if someone was getting their treatment through Northwestern and you were the contact person for them, would you be able to help navigate with a lot of all of that information that you just gave us? Would you be the person who would kind of help make all of that stuff happen if someone were to need support?
Absolutely. So either myself or, I used to be an N of 1 and now I'm an N of 2. So I have a nurse navigator that works with me. Her name's Jen. And either one of us, definitely that's part of this position, is taking a patient through step by step, not only the fertility preservation, but how can I afford this? there's a lot happening at the onset of a diagnosis, right? The last thing that you should have to also worry about is Googling, how can I afford fertility treatments? Let people who do this all day long kind of help guide you through that. Absolutely.
And I know you've been doing this a long time. You were an immense help to me when I went through all of this. Is there any other thoughts that you want to kind of leave us with?
Yeah, I mean, I have been here a long time. And, what I've seen over the 10 plus years that I've been here is this AYA program really changed the landscape of how we're caring for our young adult patients. And it is about time because, we know from years and years and years of study, decades of years of studies, that young adults were often overlooked in the cancer landscape. And that affected all of us in really terrible ways. It affected our enrollment in clinical trials. It affected survival rates. And I'm just so thrilled to see not only Northwestern, but other organizations and academic medical centers around the country step up to that and say, we're not going to take this anymore. We're going to change how we're treating our young adults. And we're going to ensure that for our young adults and even our pediatric patients that we're talking about fertility and that we're not just patting people on the head and saying, oh, you're going to be okay. Just let me, get rid of your cancer. You can worry about the rest of your life later. No, that's not acceptable anymore. And so I am thrilled to be a part of such a huge organization here in the Robert H. Lurie Comprehensive Cancer Center at Northwestern, where we do take this seriously and we want to ensure that our patients are well cared for as a whole patient, not just their cancer diagnosis.
Mm-hmm. Yeah, I know from so many patients what an incredible resource you are and even your role in getting that legislation passed. So we're very thankful to have you, Kristen. If people want more information about this topic or even want to get in touch with you, could you provide us some information there?
For sure. So we have a website. It's fertilitypreservation.northwestern.edu. There are some tutorials on there, a decision tree. My contact information is there. And if you want, you can certainly just call me. I have a fertility hotline that rings right to my desk. The phone number is 312-503-3378. Now, due to COVID, I'm not always sitting at my desk. I am, certainly seeing patients in clinic, but if you don't catch me live, leave me a voicemail. I'm typically getting back to people within 24 to 48 hours on a weekday.
Amazing. Well, thank you both so much, Jen and Kristen, for joining us today on The Scoop. This has been so helpful to learn about what AYAs need to know about cancer and fertility. So thank you both again. Thank you so much for joining us today on The Scoop. We hope you enjoyed our conversation and learned something new. If you want to hear more of these in the future, make sure you like our page at Lurie AYA. We hope you have a happy day.